Have you heard about FDA-approved Vyvgart Hytrulo, efgartigimod alpha, and hyaluronidase QVFC for subcutaneous injection? Visit vyvgarthcp.com to discover clinical trial data and explore patient profiles. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, and welcome to the Neurology podcast. This is Dan Ackerman from St. Luke's University Health Network, and today I have the privilege of interviewing Silja Räty of the Helsinki University Hospital about her paper titled IV Thrombolysis in Basilar Artery Occlusion, Outcomes and Comparison with Endovascular Thrombectomy. This was published in the April 23rd print edition of the journal Neurology. Silja, welcome to the podcast.
Thank you for having me.
Well, it's such a pleasure to get to talk with you, and particularly to be able to talk about such an important paper and such a scary type of stroke. I mean, no stroke is good, but basilar artery occlusions, that really is the stuff of nightmares sometimes. I really enjoyed your paper, and before we get to the results, I just wanted to go over a little bit of background. In the last several years, there really have been a couple of attempts to look at the relative value of IV or systemic thrombolysis in patients with large vessel occlusion, now in the era of thrombectomy. Systemic thrombolysis has been around for a solid 25 years, but then 10 years ago, thrombectomy really came in vogue, and now frequently, of course, we're using both whenever possible. So in that setting, could you just give us a little background about what your motivation was for doing this particular study?
There have been several studies on recanalization treatment, which includes IV thrombolysis and thrombectomy, but mostly in anterior circulation large vessel occlusion, but less so in basilar artery occlusion. And when it comes to basilar artery occlusion, as you mentioned, it has one of the highest mortalities and morbidities among stroke, especially without recanalization. So it imposes enormous burden on patients and healthcare systems. So the first motivation has always been to know how we can treat these patients as effectively and safely as possible to decrease that burden. And the second motivation, which comes closer to your question, is that after a long period of only observational studies on basilar artery occlusion, 4 randomized control trials on thrombectomy versus best medical treatment in basilar artery occlusion were published in recent years, and 2 of them showed that thrombectomy was superior to best medical management up to 24 hours after onset. But what was unfortunate was that only minority of the patients in the best medical treatment arm were treated with IV thrombolysis, which after all has been the standard of care for ischemic stroke. So therefore, there was also a bit worried that we would ignore IV thrombolysis after these results, even though its availability is way better than thrombectomy and thus can be delivered faster in most centers. So that's why we wanted to study whether IV thrombolysis still has a role in acute treatment of basilar artery occlusion and compare outcomes after IV thrombolysis and thrombectomy in our center.
We're comparing endovascular therapy to best medical management, but the best medical management that was most often chosen was not a recanalization therapy, just something that was proven to prevent perhaps worsening thrombosis or secondary thrombosis. But in that case, we're sort of comparing apples to oranges in terms of looking for a benefit or an outcome.
Exactly.
Now, in reading this, I was really interested to read about your hospital's protocol for IV thrombolysis, because it's a little different than the protocol I'm accustomed to seeing at most centers. Many of the stroke centers that I'm familiar with still place a limit on IV thrombolysis of 4.5 hours from last known well, and they may utilize a wake-up stroke protocol to select certain patients. But your approach was a little different. So could you tell us a little about your criteria for IV thrombolysis and how you got to it?
That is correct. And I acknowledge that this is something that is a bit different from most centers. But due to this really pessimistic natural history of basilar artery occlusion, Our center has been quite aggressive in treating these patients with IV thrombolysis since 1990s. And what this means is that we have used longer time windows for basilar artery occlusion patients, provided that certain criteria are met. And these criteria include lack of absolute contraindications for IV thrombolysis, that there are not too extensive irreversible ischemic changes in the posterior circulation at baseline, and that the clinical presentation of patient suggests that there is something to save with recanalization. So we have kind of applied this tissue clock approach in basilar artery occlusion, and I've published previously a paper that showed that some patients can benefit from IV thrombolysis up to 24 to 48 hours. But obviously, if the patient has sudden loss of consciousness, arrives 24 hours late, and has extensive brainstem ischemia, we don't treat them with recanalization therapy, as the prognosis is really poor anyway. So we consider many different variables when we treat these patients in longer time windows.
I think it does make a lot of sense to be a little bit more aggressive. We know that these are really challenging strokes to treat, challenging strokes to recover from. And in the case of a large vessel occlusion in particular, we're often very confident about cerebral ischemia being the source of somebody's symptoms. For patients who have other types of posterior circulation symptoms in the absence of a basilar artery occlusion, the fact of ischemia might be a little bit more difficult to discern as opposed to other competing diagnoses, other vestibulopathies or cranial neuropathies for other reasons. And I thought it was also very interesting that at your center you use adjunctive anticoagulation, first with unfractionated heparin and then in more recent years with low molecular weight heparin. Is that right?
Yes, that's correct. And that's because we have seen that one of the main issues with basilar artery occlusion patients is that they get quite often rethrombosis despite recanalization at the first place. So that's why we have used it quite a lot. And we started with unfractionated heparin, but have in recent years only used low molecular heparin if we suspect that there is still residual thrombosis after recanalization therapy.
Now, with all that background out of the way, could you please summarize for us a little bit about how your study was designed and tell us what you found?
Okay, so this was an observational single-center study on patients treated with recanalization therapy for basilar artery occlusion in our center between 1995 and 2022. And our main focus was on IV thrombolysis. So first we looked at the 245 patients treated with IV thrombolysis alone and found out that almost half had favorable functional outcome at 3 months. But on the other hand, mortality was 36% and 11% had suffered symptomatic hemorrhage. And next we examined the predictors of functional outcome after IV thrombolysis and found out, and this is very much in line with previous studies, that the main predictors were patients' age, stroke severity, and extent of already visible ischemic changes in baseline imaging. But interestingly, not time when we adjusted the analysis. And then finally, we compared patients treated with IV thrombolysis alone to those treated with thrombectomy with or without IV thrombolysis during later years of the study period when thrombectomy became increasingly part of routine care. This was between 2010 and 2022. And in this cohort, basilar artery occlusion patients receiving IVT alone had higher odds for favorable functional outcome when we adjusted the analysis for relevant baseline differences and outcome predictors.
Stepping back to the first part of your study, from the very beginning, looking at the IV thrombolysis only cohort, again, just to make sure I've got this right, we're talking about 245 patients. And in that group, there was a 67% recanalization rate, about a 46.5% rate of good outcome, meaning modified Rankin scale between 0 and 3, and a symptomatic ICH rate of 11%. Is that right?
That's correct, yes.
Now, that rate of recanalization at 67% and a good outcome of nearly 50% seems a little bit beyond what we might otherwise expect for patients with basilar artery occlusion that would qualify for alteplase or tenecteplase at your average stroke center. Maybe that's some of what's led to this more nihilistic view of treatment in basilar artery occlusion. but have you considered why patients did so well in this particular study?
Well, I think that the frequency of favorable functional outcome is pretty much in line with studies on recanalization treatment for basilar artery occlusion and almost equal to the reports from the thrombectomy groups of randomized controlled trials. But however, the outcome of the later cohort in our study from 2010, which were treated with IVT only, they had extremely favorable functional outcome with 8% achieving modified ranking scale, which is the scale we use to assess the outcome 0 to 3 at 3 months. And especially in the later cohort, the patients who were treated with thrombolysis only had somewhat milder symptoms than patients treated with thrombectomy and less often high clot burden in the basilar artery. So some baseline variables seem to have influenced the treatment selection during the later years of the study. However, due to these potential confounders, we used really rigorous statistical methods in the adjusted analysis. But when it comes to the whole cohort from 1995, I think and I hope that one thing that has potentially contributed to the favorable outcome is that in our center we have established quite early on well-organized and quick stroke chains, and we are a high-volume tertiary center, so I think that affects the outcome as well. And in addition, one thing that may have affected the result is that patients with significant pre-stroke disability are not usually admitted to our center, so the patients in our cohort have better chance to achieve favorable functional outcome.
One of the advantages of focusing on IV thrombolysis that you mentioned in the paper really has to do with its availability at centers that are much more widespread compared to busy tertiary care centers where we're frequently performing thrombectomy. Do you feel like these results are potentially reproducible at centers throughout the regions like this?
Well, I would like to think so, because the main thing obviously is the speed. We have to be as fast as possible when we treat these patients with recanalization treatment. Even though we have used longer time windows, there are still some patients who have to be treated as quick as possible to reach favorable functional outcome. But I also think that some patients benefit from thrombectomy. So after starting IV thrombolysis for eligible patients, most benefit from transferring to thrombectomy-ready centers.
In fact, in your cohort, in the IV thrombolysis versus endovascular therapy group, only 43% had a favorable outcome in the endovascular therapy group, whereas, as you pointed out, 58% really in the IV thrombolysis group. It was actually found to be comparable to superior, although again in an observational cohort. Is that right?
Of course.
Yeah.
Yes, that's correct.
Wow. Now, let's talk a little bit about complications. The symptomatic hemorrhage rate early on was just over 11%. And in the later cohort, the IV thrombolysis patients had a symptomatic hemorrhage rate of about 6.7%. Now, that's a little higher than the 6% that we often quote. And of course, the 6% bleed risk overall really goes all the way back 25 years to that NINDS TPA study. So in your analysis, do you think that with these rates of hemorrhage and particularly symptomatic hemorrhage, that there's still a solid risk-benefit ratio?
Well, it is true that the rate of symptomatic ICH in our study was higher than in most studies on recanalization treatment, especially when we look at the whole cohort of patients from 1995. Although I have to mention that comparing different studies is not always easy because of different definitions of symptomatic ICH. Okay, but however, as you mentioned, in the more modern cohort from 2010, the hemorrhage rate was 6.7%, which I think is approximately same as intervention trials on basilar artery occlusion. And I think that this development is probably due to change from unfractionated heparin to low molecular heparin as an add-on antithrombotic therapy. And I think that the 6.7% hemorrhage rate more reflects our current practice than the 11% rate.
So with 6.7% of symptomatic hemorrhage, does that possibly also represent just the overall increased hemorrhagic risk for patients that have large vessel occlusion and particularly posterior circulation large vessel occlusion, as opposed to comparing that to all comers when we talk about stroke and risks of symptomatic ICH with thrombolysis?
Well, I think that to some extent, yes, but I acknowledge that also the longer time window must or can play a role in this a bit higher hemorrhage rate. However, as I mentioned earlier, we don't treat patients with extensive baseline ischemia with IV thrombolysis, and that's how we try to decrease the risk of hemorrhage in these patients.
So I think there's a lot of great practical advice in this paper, and I really appreciate you sharing some of your expertise with us, not only in regard to this paper itself, but with regard to being a little bit more aggressive with basilar artery occlusion and making sure that when we're comparing interventional studies or using studies to compare different interventions to each other, that those interventions are expected to produce a similar result, hopefully recanalization. Bearing that in mind, how are you going to apply these results moving forward?
In my opinion, the main take-home message from our study is that we should not ignore IV thrombolysis as the first-line acute treatment in basilar artery occlusion, even in longer time windows than 4.5 hours, if there are no other contraindications and something to save based on baseline imaging and symptoms. And this is especially important considering that IV thrombolysis is available in most centers, as you mentioned, whereas thrombectomy is not. And I want to highlight that because our study is observational, it does not negate the results of randomized controlled trials on basilar artery occlusion. So I'm not suggesting that we should not treat patients with basilar artery occlusion with thrombectomy. That being said, I think that we should consider whether all patients with basilar artery occlusion need thrombectomy, or are there some for whom IV thrombolysis alone is the best option. And this is not just based on our study, but also other studies indicating that, for example, patients with mild symptoms and basilar artery occlusion might do well with IVT alone. However, how we choose these patients in the future is a bit out of scope of this study, but I think this is something of interest in the future.
I mean, it is observational data, but I think the numbers are pretty compelling. Thank you so much again, Silja, for talking with us today. And I would encourage everyone to take a look at the full paper, IV Thrombolysis in Basilar Artery Occlusion, Outcomes in Comparison with Endovascular Therapy, either online or in the April 23rd print edition of the Neurology Journal.
It was my pleasure. Thank you very much.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.